Then the conditions that we're specifically going to talk about would be dyspepsia, GERD, diarrhea, constipation, and C. diff. Again, wonderful things to talk about post-breakfast. So I want to just set the stage with some specific key points about older adults with GI conditions. Most GI signs and symptoms when an older adult really could signal a pathological condition. So we really need to take it seriously and evaluate that very deeply. And also we know that medications that we use to treat their comorbidities could also cause some GI signs and symptoms. We unfortunately... Closer. Okay. Is that better? Can you hear me? Okay, terrific. Our older adults, of course, they don't come with just one problem. We know that they have 5 or 6 comorbidities and therefore, can have polypharmacy, and therefore our treatments for their chronic conditions can also cause other problems, even GI issues. And our older adults, as we know, they don't present typically like a younger adult or textbook, right? They have atypical symptoms, and they might have very mild symptoms that could indicate very severe disease. So we need to, again, take any of those issues very seriously when an older adult comes in with a GI complaint. They do tolerate the treatments well, just like we would treat with a younger adult, but just remembering that they're more susceptible to adverse events. Remember, because the drugs that we use with their metabolism, excretion, as well, again, as polypharmacy and drug-drug interactions, we have to be considered. So that just kind of sets the foundation as we move forward for this lecture. So dyspepsia, that's going to be our first topic. And really, as an overview, what is dyspepsia? So that your patient may complain of bloating, burping, a vague discomfort in the upper abdomen. They have postprandial fullness, or maybe some epigastric pain. So there's a broad differential diagnosis here that we have to consider with dyspepsia. Could be peptic ulcer, could be GERD, maybe H. pylori, but we also have to think malignancy. There could be even a functional dyspepsia, but that's only after you have ruled out all of the other causes to know about a functional dyspepsia, because there's really no obvious cause with that. There could be some risk factors of functional dyspepsia, like smoking, female gender, a history of anxiety or depression. My older adult patients tell me they were diagnosed a long time ago with, honey, I got a nervous stomach. How many of y'all have heard that? So that could be functional dyspepsia if you know that, they've had that, maybe their whole life. But if you have a new complaint of dyspepsia, that should, raise some radar for you. So the diagnostic approach to that is, again, we probably need to get some referrals for endoscopy. Abdominal imaging may be an indication for possibly a CT. They may even look at a gastric emptying study and H. pylori testing. Of course, you can do the H. pylori testing, obviously in your office, maybe do a breath test. But just remember, if they're on a PPI, they need to be off of that for 2 weeks before you do the breath test. So you could do even a stool antigen. That is another option there. But if you have ruled out all of those other causes, they've been to GI, they've had the workup, they don't find anything, then you could possibly use that diagnosis of a functional dyspepsia. And so what do we do about that? You could use a PPI, but really in the literature, the symptom improvement is very low with that. Tricyclic antidepressants have shown to be beneficial, but again, we know in our patient population, that's a difficult class of medications to use, right? They're on the Beers criteria doesn't mean you couldn't, right? Risk versus benefit. It's that warning light that, hey, you need to think about that before prescribing for an older adult. I do have some that have been on like amitriptyline for their nervous stomach for decades. probably even, more than decades. And they've done fine, but, it's evaluating that every year and saying, is this time for you to come off of it? Should we look at something else? So there are some other things like peppermint oil, caraway oil. Maybe it's just lifestyle changes, looking at their food, diet. So again, we always go back to the lifestyle changes. If they smoke, quit smoking, alcohol, is there a food trigger? So going back to some of that, basic things that we do for almost all of our patients to look at dyspepsia. But again, I think the big takeaway is if it's a new complaint, then you really do need to look at endoscopy and imaging to rule out any sort of serious cause. The next topic we're going to look up is GERD, so gastroesophageal reflux. And older adults have a really high tolerance for these symptoms and can put them at risk for very untreated severe illness, such as, erosive esophagitis, because their symptoms might be mild. And again, they usually can have atypical symptoms. It could be maybe just epigastric pain, nausea, bloating, belching. We also could see maybe cough or wheezing, some more maybe respiratory type symptoms. And in addition, our older adults may indicate underlying cardiopulmonary disease or process. So when they present with GERD, you always need to keep back in their head, is this cardiopulmonary and not truly GERD, and just maybe throw on a PPI. And they can have a higher risk of complications, with Barrett's, erosive, or even cancer. And I've seen this in practice that an older adult has presented with some mild or atypical GERD symptoms. Finally they get to the right provider that sends them for a workup, and they do have a esophageal malignancy. Especially if you think if they've had a long history of smoking, alcohol, you need to, again, have those red flags and those alarm symptoms of when you need to refer out for these patients. So again, an older adult may really benefit from an earlier endoscopic evaluation, even with vague symptoms. So again, I think it's important that mild symptoms doesn't mean mild disease for our older adults. So alarming symptoms: unintentional weight loss, GI bleeding, of course, dysphagia, odonophagia, painful swallowing, anemia, persistent vomiting. Those are all those alarm symptoms, again, that you need to refer immediately. The goals of treatment are the same as the younger. We want to alleviate symptoms, heal any erosive esophagitis, prevent complications, and maintain remission. So again, treating them like we would any age group, but possibly doing that earlier referral for endoscopy. So risk factors for GERD that we can look at is we know there are some medications that decrease the lower esophageal sphincter, things like theophylline, nitrates, calcium, channel blockers, anticholinergics. Also, our patients with comorbidities of diabetes, Parkinson's, ALS, they also have increased risk factors for GERD, as well as obesity. So again, some of this could be lifestyle, thinking about, even food triggers, and weight. Some of our patients also have a hiatal hernia, which also puts them at a higher risk of GERD, as well as impaired esophageal peristalsis. As an older adult, we do see that their esophagus, may not work quite as well as they did when they were younger. Sometimes just not enough spit in your mouth, right? So if we give drugs that maybe for their urinary incontinence or any other possible drugs that cause dry mouth, that can also cause trouble with them chewing and swallowing and really not being able to chew their food well, which can also lead to more symptoms of GERD. So investigating all those other possible issues. So treating our patients, again, we've heard this, I think, time and time again over the past couple of days at the conference with lifestyle and dietary modifications. We should always think about that first before throwing a medication at our patient. Maybe we talk to them very seriously about weight loss. What are you eating? Avoiding meals 2 to 3 hours before bedtime. Stop smoking, and simply just elevate the head of the bed.